So today what we are going to discuss is one of the most important analytical and logical topics of orthopedics, that is gait analysis. So I do believe that the people who say that gait analysis and assessment is a very subjective topic, it can't really help you much in the diagnosis of pathology. Those people absolutely deserve flowers thrown on their face, but with the pot, because gait analysis is absolute physics, it's absolute logic. So before the patient speaks anything, before you ask anything, as soon as the patient walks into your OPD, it really helps you in ruling out multiple pathologies, if not diagnose, which in the end will help you clinch the final diagnosis of the patient. So without further ado, let us begin with our today's session on gait analysis. So what our plan for today is, we are going to understand the core concept, the logic behind various common orthopedic gaits, right? Then we are going to analytically compare the basic differences in between the gaits, which helps us to clinch to the diagnosis. And at the end, we are going to discuss some key which will help us in bang on finding the type of gait which we are seeing in the patient. So without further ado, let us begin. So in orthopedics, which are the most confusing gaits in which we get jumbled up is Trendelenburg versus antalgic versus short limb, right? So as a protocol for this video, we are going to keep the right hip as the affected hip. Right hip is the pathological hip, and we are going to understand the various mechanisms based on that. Okay. So the basic crux, how do you analyze a gait? The first thing you see is whether the trunk is lurching, dipping, tilting to the affected or non-affected side, right or left. We observe the stance phase of the affected side, whether it is decreased, equal as compared to the opposite side. We understand the stride length of the affected side, whether it is decreased or the equal, the amount of distance traveled. And we are going to observe whether the pelvis droops or tilts on the affected or unaffected side. And most important, we are going to check for whether there is a pain component, while walking, is there any instability component. So these are the important things which we observe before commenting on the gait and reaching to the type of gait and diagnosis. Okay. So without further ado, this is a flow chart, but before that we'll understand the basic core concept of various orthopedic gaits. Okay, so starting with the most common, Trendelenburg gait. Okay, so in this patient, right hip is the pathological hip, in which Trendelenburg gait is positive. Okay. So let's suppose the patient weight bears on the right lower limb. That what does that mean? That right lower limb is in the stance phase. Okay. So normally what happens is, whenever the patient weight bears on the right side, the right abductors contract, and which pulls the right pelvis down. As you can see, it pulls the right pelvis down by the contraction of right sided abductors, which indirectly pulls the left pelvis upside on the proximal side, right? So whenever initially, let's suppose the patient is standing on both legs and the patient stands on right leg, that is the affected leg, then immediately the right sided abductors contract, which pulls the right pelvis, right ASIS inferiorly, and left ASIS goes superiorly. Okay, so this is the normal mechanism. So whenever there is Trendelenburg gait, what happens is, let's suppose there are different pathologies, but most commonly right abductor weakness is there. Okay, so whenever right abductor weakness is there, the right abductors will not contract, or there will be weak contraction. Okay, so it will not be able to generate sufficient force to pull the pelvis inferiorly, to pull the right sided ASIS inferiorly, and pull the left sided pelvis superiorly. So what happens is left sided pelvis droops due to right sided abductor weakness. Okay, so whenever there is a pathology in right abductor, left side pelvis droops. Okay, so when the left side pelvis droops, the left side body droops. To decrease the load on the left side, the trunk tilts towards the right side, which is the affected side. Okay, affected side is the right side. So I repeat, so right sided is the pathological side. The patient stands on the right side. What happens is right abductor weakness, so left sided pelvis droops. Okay, so now to decrease the load on the left side, trunk tilts towards the right side, that is the affected side, and this happens when? Only during the stance phase of the affected right side, right? Okay, so the basic findings we understood in Trendelenburg gait is the trunk tilts towards the affected side. Why? What is the reason? The reason of trunk shifting is important to understand. It is because of the weak abductor mechanism. So it is the whole mechanism we are going to discuss in the subsequent slide. So the abductor mechanism is weak. To compensate that, body adapts a tendency to shift the trunk towards the affected side in the stance phase. Okay. Now, second point is, important point to observe is pelvis droops on the opposite side. Okay, because the right abductors or abductor mechanism is not able to pull the ipsilateral pelvis down. So the pelvis droops on the opposite side. Understood? And there is usually in the classic Trendelenburg gait, there is no pain component. So when does the stance phase and stride length decrease? When the patient doesn't want to weight bear more on the painful limb. I repeat, when the patient doesn't want to weight bear more on the painful limb. So body adapts and decreases the stance phase and stride length. Okay, so we are going to discuss in the antalgic gait. So in this patient, there is, in the classical Trendelenburg gait, there is no significant pain component. So stance phase bilaterally should be equal. Stride length bilaterally should be equal. Okay, so now we discuss that when is Trendelenburg gait present. So whenever there is any pathology in abductor mechanism, so it is a liver system. So okay, so whenever there is some pathology in the fulcrum, whether there is some pathology in the liver, and whether there is some pathology in the effort. So what is fulcrum? Fulcrum is at the junction of femoral head and acetabulum. Okay, so at the junction of femoral head and acetabulum, whenever there is pathology. What is liver arm? It is femoral neck and the intertrochanteric region, and these are bony things. How does the mechanism work? By effort. So by gluteus medius and gluteus minimus. Okay, so what are the possible common pathologies affecting the fulcrum? So it is osteonecrosis of hip, developmental dysplasia of hip, dislocated hip, TB hip, various stages. Okay. Now, whenever the liver arm is affected, like in coxa vera, non-union neck of femur, and greater trochanter avulsion. And when effort is lost, when the abductors are weak. What are the abductors? Gluteus medius and minimus. So when are they weak? Whenever there is L5 nerve root palsy, hip abduction is weak. This is a very significant finding. Even you have to observe in foot drop to rule out L4, L5 lesion. Okay, so whenever there is hip abduction, L5 nerve root palsy, it causes weakness in the effort. Superior gluteal nerve palsy, it causes weak abductors, gluteus medius minimus tendinitis, polio, and postoperative case complication of THR. Okay, so that was the basic core concept of Trendelenburg gait. I hope you have understood. Okay, now moving further, what is the core concept of short limb gait? Okay, so what is the core concept? The purpose is to functionally shorten the effective body length while weight bearing on the affected side. Okay, so let's suppose there is right-sided limb length discrepancy. There is right-sided shortening in the lower limb. So to compensate the shortening, the body has adapted various mechanisms to functionally shorten the effective body length by various mechanisms on the opposite side, on the trunk, various mechanisms we are going to understand. So the compensation is based on the shortening. Okay, so this gait is usually apparent if there is more than 2 cm shortening. Okay, so what happens is, if it is 1.5 to 2 cm, how does the body compensate? It compensates by right-sided pelvic tilt. It compensates by right-sided pelvic tilt, which takes the lower limb at the equal level. So the first compensator mechanism is right-sided pelvic tilt. Am I making sense? Okay. Now, if it is more, the discrepancy is more than 2 centimeters, then depending upon the discrepancy, the various logical mechanisms the body has adapted. First is to lengthen the right side. So right side is short. As a protocol, the right side is short. Okay, so the first thing we can do is lengthen the right side. How do we lengthen the right side? We can't, there might be bony shortening. Okay, so we need to change the attitude. So how does the body adapt? By equinus over the right side, right? And if there is further limb length shortening, how does the body adapt? By functionally shortening the opposite effective body length. Okay, so it shortens the left side. How does it shorten? By flexing the hip and knee over the left side. So left side is shortened, both limbs become equal, and that is the adaptory mechanism. Okay, so up to 5 centimeters. So we understood up to 1.5 to 2 centimeters right-sided pelvic tilt. Up to 5 centimeter lengthen the right side, right-sided equinus of the foot, and more than 5 centimeter, it is a combination of pelvic tilting towards the right side, that is the ipsilateral side, hip and knee flexion over the contralateral left side to functionally shorten the opposite side, and equinus of the foot on the ipsilateral right side. Am I making sense? Okay. So the basic points in short limb gain are: trunk tilts on the affected side, right? Trunk tilts on the affected side. And one more important thing is the trunk tilting starts before the stance phase. If you imagine a short limb, short right lower limb, the body trying to compensate. So before the stance phase starts, to take the foot in the plantigrade position at the ground, to make the foot touch the ground, the trunk tilting starts before the stance phase. Only then we will get the stance phase. No, so we'll compare it. So this point you understand right now, that the trunk tilt starts before the stance phase and persists. Okay. Now, second is pelvis tilt on the same side, that is the affected side. And usually, if there is no pain component, the stance phase is equal. As we already understood, the patient, whenever there is pain component, the patient tries to decrease the weight bearing on the painful side, so the stance phase is decreased. But in this, in the frank short limb gait, the stance phase is equal. And additionally, ipsilateral equinus or contralateral hip or knee flexion. Okay, so I hope you understand all these points. So trunk tilting over the affected side to functionally take the foot to the ground in the plantigrade position and effectively decrease the body length on the opposite side. Second, pelvic tilt on the same side, stance phase equal, ipsilateral equinus attitude or contralateral hip or knee flexion. Okay. And now the third gait is the antalgic gait. So any pathology causing pain on that side, I just mentioned 3: osteoarthritis, fracture or tendinitis, but all the painful pathologies come in antalgic gait. Okay, so there might be painful hip or knee. So what our body wants to minimize the time spent bearing weight on the affected painful limb. So how does the body do that? The body decreases the stance phase and shorter stride length. So shorter steps, distance covered by the painful limb is less. Okay. Additionally, tilting of the trunk to the affected side. Okay, so this is very confusing. I'll explain you why. So logically, what do you think? The right side is painful, so to decrease the pain on the right side, the body tries to shift the trunk on the left side, but it is wrong. The body tries to shift the trunk to the affected side. Why? I'll explain you. So it shortens the body tries to shorten the lever arm of body weight. So simple example I will give you. If you want to hold a bucket, right? So you have two options. Either you hold the bucket with one hand close to your abdomen, or either you hold the bucket very lateral to the abdomen with the hand. You'd obviously prefer, how do you prefer? You will prefer to hold the bucket close to your abdomen, more medially. Okay, why? Because we want to decrease the torque required, the moment required. So what is torque? It is force into distance. So when we decrease the distance, the moment or the torque required is decreased. So similarly over here, so if there is right sided painful hip, let's suppose there is right sided painful hip, so our body tilts the trunk to right side. Why tilts the trunk to right side? So that the distance, moment arm decreases, so that the painful abductors demand is decreases, which reduces the pain. Am I making sense? I hope I am clear. I am making myself very clear. Okay, so tilting of the trunk to affected side to shorten the lever arm of body weight, which decreases the demand on hip abductors and reduces pain. Okay, so the characteristic finding, most important, pain component, okay, which you might see on the face. Okay, then the trunk tilting towards the affected side. I hope I am making sense. Yes. Now decrease stance phase and decrease stride length. Okay, so that was all. That was the core concept of the basic 3 orthopedic gaits. I hope I am very clear. Okay, now we are going to analyze the basic core and the crux, the difference between the 3 gaits. How do you analyze? Okay, so the first thing, fasten your seat belts. The first thing we see is whether the trunk dips or tilts. So let's suppose the right side is affected, for understanding. Okay, right side is affected. Now the trunk tilts or dips to right side. If the trunk tilts or dips to the right side, that is the affected side, what could be the possible gaits? It could be a short limb gait, it could be an antalgic gait, or it could be a Trendelenburg gait. Okay, so now how to further differentiate? Come on, how to further differentiate? We'll understand. So we'll look at the stance phase and stride length. Okay, so if the stance phase and stride length is decreased, additionally there is component of pain. What does it indicate? Antalgic gait. Finish? Clear? Okay, so whenever there is trunk shifting, tilting towards the same side with decreased stance phase and decreased stride length with a component of pain, bang on, it is a classic antalgic gait. Okay, now if the stance phase is equal on both the sides, then we have to understand whether it is a Trendelenburg gait or a short limb gait. What further do we look at? We look at the pelvic tilt. Whether there is pelvic tilt. Okay, and additionally we look at the trunk tilt. When the trunk tilt starts, that is what I had explained in the beginning. I will understand again. Okay, so look at the pelvic tilt. The trunk is shifting towards the same side, right, in both the Trendelenburg gait and the short limb gait. But when does the tilt start? That is also important. Okay, so if the pelvis tilts or dips towards the unaffected opposite side, that is the left side, we had understood in the core concept, because then it is a Trendelenburg gait. And because the pelvis droops on the opposite side. Am I making sense? And when does this mechanism start? When the patient weight bears. An ineffective abductor mechanism of the affected side, causing the drooping over the opposite side, and as a compensatory mechanism, the trunk is tilting most towards the same side as a compensatory mechanism for weak hip abductor mechanism. Okay, so trunk tilts mostly during the stance phase. Am I making sense? During the stance phase. Okay, now if the pelvis tilts or dips towards the affected side, what does it indicate? It is a compensatory mechanism for the shortening, so it is a short limb gait. And additional feature is trunk tilt starts before the stance phase and persists. Am I making sense? Because it is a compensatory mechanism. Body wants to take the foot in the plantigrade at the ground. Okay, so this is the lovely flow chart to understand, bang on, to figure out the analytical difference between the 3 common, confusing but very interesting gaits of orthopedics. Okay, Hope I'm making sense. So now this is the key. We'll quickly revise. Antalgic gait, trunk tilts or dips towards the affected side. Stance phase is decreased. Stride length is decreased, and there is no pelvic tilt or droop in the classical antalgic gait. In Trendelenburg gait, the trunk shifts towards the affected side. Stance phase and stride length is equal. Pelvis droops on the opposite side. Trunk tilts mostly during the stance phase. After the stance, only the mechanism starts. Okay? And what is the purpose of the trunk tilt? It decreases the load on the weak abductors to prevent pelvis from drooping on the opposite side. Okay, now what is short limb gait? The salient features: trunk tilts towards the affected side, stance phase and stride length are equal bilaterally, pelvis tilts on the same side, that is the affected side, trunk tilt starts before the stance phase and persists, and the purpose of trunk tilt is to functionally shorten the body length when the patient is weight bearing on the shorter limb. Okay, so the most important is to understand the purpose of 3. So what is the purpose of the trunk tilt? In antalgic gait is to decrease the momentum. It's to decrease the momentum by decreasing the distance. Okay, because the patient wants to decrease the required force or moment for the abductors to decrease the pain. That is the purpose of antalgic gait. Now what is the purpose of Trendelenburg gait? Is to decrease the load on the weak abductor to prevent pelvis from drooping on the opposite side. Okay, and what is the purpose of short limb gait? Is to functionally shorten the body length when weight bearing on the shorter limb to accommodate the limb length discrepancy. I hope I am making sense. This is very clear. I hope so. Okay, so now one more analytical point is about the observation of flexion at the hip and knee, the compensation. So whenever there is flexion at the hip and knee, if it is contralateral, we already know that it is a short limb gait. Why? To functionally shorten the unaffected limb. Am I making sense? Clear? Now, when do we want the ipsilateral flexion at hip and knee? When we want to functionally shorten the affected limb. When do we want to functionally shorten the affected limb? For a compensatory mechanism. Guess what? So, for a compensatory mechanism, whenever there is a foot drop, there is high steppage gait due to equinus attitude of the foot. So, due to equinus, there is effective lengthening of the affected side. So, to functionally shorten the affected limb, the body compensates by flexing the hip and knee. That is the classical high steppage gait. Okay, so I hope you understood the concept, you have understood the analytics. Okay, now we are going to understand some of the special gaits and the biomechanics behind them. Okay, so commonly we see a quadriceps gait, which is classically known as the hand to knee gait. The name itself tells a lot of things. Okay, so what is when it is common? In polio, stroke, cerebral palsy, myopathy. Okay, so normally what happens is knee is kept a locked in extension due to quadriceps functions is extension at the knee, keeping it stable locked position while ambulating. Now whenever there is weak quadriceps in all of these pathologies, what happens is there is buckling of the knee due to weak extensor action of the quadriceps, buckling of the knee. Now whenever there is buckling of the knee, this part is weak, body can't do about it. Okay, so how does the body compensate? Why it is buckling? Because the weight is going like this, so this part is not able to compensate the weight. So the body tries to compensate by shifting the center of gravity anteriorly. The center of gravity is shifted anteriorly. How do we shift? When the center of gravity is shifted anteriorly, the force goes in this direction, so which prevents. So what was happening? This was suppose the normal knee. Whenever there is force acting, it buckles, but the body tries to compensate by anteriorizing the center of gravity by forward tilting. So the center of gravity, as it goes anteriorly, it prevents the buckling of knee. Additionally, the compensatory mechanism the body adapts is pushing the knee posteriorly. So whenever there is buckling and it is pushed, it stays in extension. So the two compensatory mechanisms, as I explained, is first is person leans forward for the center of gravity to go anterior to the knee, which indirectly pushes the knee posteriorly, which causes the knee extension. And the second is hand to knee gait. The hand pushes the anterior thigh posteriorly to prevent the buckling. Okay, so that is the basic core mechanism of quadriceps gait, which is seen in polio, stroke, cerebral palsy, and myopathy. Okay. Now further going a little bit opposite of that, gluteus maximus dysfunction gait. It's also known as rocking horse gait. Okay. So normally what happens is, this is the lateral position of the patient. So normally the gluteus maximus maintains hip in extension. So hip is locked in extension. Okay. Now what happens if hip is locked in extension whenever the patient weight bears. Okay. Now in Gmax weakness like inferior gluteal nerve palsy, hip locking in extension does not occur. So what happens is, due to the center of gravity, this is the lateral position, hip extension is weak, so flexion buckling at the hip happens. So how do you compensate? We compensate similarly what I explained you in the quadriceps gait. We compensate by shifting the center of gravity posteriorly, so that it pushes the hip anteriorly into extension. So compensation is by trunk shifting posteriorly, so that the center of gravity goes posterior to G max, as I have shown in the figure, which keeps, as the center of gravity goes posteriorly, it keeps the knee in flexion and prevents the buckling. Okay, so it decreases the effort to keep the hip in extension. And so the compensatory mechanism is forward pelvic thrust and backward lurch of the trunk. And how in backward lurch of trunk, so definitely there would be increased lordosis. Okay, so both of them are a bit opposite. The mechanism is the same, but to understand both of them, you can remember quadriceps and gluteus maximus dysfunction gait. Both of them you can remember and analyze together. Okay, so now some just miscellaneous gaits. I'll go quickly. So if a wide base gait is there, reeling gait, clumsy, staggering towards and move side to side, is seen in classical cervical myelopathy, cerebellar ataxia, and alcoholism. So commonly used word is wide base gait, seen in cervical myelopathy. Now stiff hip gait or bell clapper gait. And what happens is, there is no flexion at the hip. So the patient lifts the pelvis and swings it forward with the leg as one piece. Am I making sense? That is the stiff hip gait or bell clapper gait. Now what is the circumduction gait? In circumduction gait, hip and knee are spastic, so they don't flex. So hip and lower limb rotates outwards roundabout. And why does this compensation happen? To avoid the foot friction scraping. Okay, commonly seen in hemiplegia. Now the scissoring gait. What happens in scissoring gait is leg crossing in cerebral palsy in the swing phase due to hip adductor spasm. Whenever there is hip adductor spasm, both sides adduction, which causes the legs crossing in cerebral palsy in the swing phase. Now what is shuffling gait? There is stooped stooped forward, short steps, fascination, and difficult to stop once the gait is initiated. It's classically seen in Parkinsonism, commonly seen in Parkinsonism. Fascination, difficult to stop once the gait is initiated, short steps, and stooped forward. Okay. Now sensory stomping or stamping gait. So whenever there is loss of proprioception, the patient slams the foot hard on the ground to sense it, and commonly seen in diabetic neuropathy, B12 deficiency, tabes dorsalis. Now Elderman's gait It is seen in TB, lower and upper dorsal spine, in which the head or chest goes backward and the abdomen there is protuberant abdomen and legs thrown wide apart. Okay, and now the gait abnormalities in the axial plane. Whenever there is intoing gait, it is called as a pigeon gait, obviously seen in excessive anteversion, and outtoing gait, which is the Charlie Chaplin gait, commonly called, and whenever there is decreased anteversion. Okay, so this was all about the gait analysis simplified for you. I hope now even you will be relating why I said that gait analysis is absolute physics, is absolute logical concept, and it's very interesting and analytical to understand and clinch the diagnosis as soon as the patient comes in the OPD, and it helps a lot in ruling out different pathologies. Okay, so this was all about the gait analysis. I hope you find it useful. You can always drop in. I would love to get your feedback in the comment section as well as on the social media page. This was Dr. Mihir Tejura signing off with gait analysis simplified for you. Thank you so much, guys.